Thank you all for coming here. I'm not an expert like Dr. Fish. I'm the guy who, I must have been out of the room when they said we need someone to do this thing with Disrupt, and then I came back in the room and they said there he is. So I have been involved in the Disrupt since the very, very beginning, when we were just Tompkins County and Schuyler County trying to put together our little PPS, and then decided that we really worked better in numbers, and that expanded to Cortland County, and now we've expanded to 9 counties. I have some slides, and they're a little bit repetitious of what Dr. Fish said, and so I'll just kind of run through those quickly, and then I apologize to Wayne, who spent so much time putting them together, and then get to what I think is more important. So we all know that Disrupt is part of the Medicaid redesign team program, essentially to get more money for Medicaid patients to improve the way we deliver service. You heard about a global cap. This is really a fundamental change in the way that we treat Medicaid patients. So right now, you see a Medicaid patient in your office, you decide that they need some treatment, you give the treatment, and then you maybe want them to go to the hospital. But they don't have a way to get to the hospital, and so maybe they don't get that test. Or you want them to go see a specialist, but you're having a hard time trying to find a specialist who will take Medicaid. Or you get them to the specialist, but they have a social problem, and that social family problem is interfering with them doing what you asked them to do, even to buy their medication. Or they get admitted to the hospital because they felt sick in the middle of the night and they didn't know what to do, and they didn't want to call you, or they didn't know how to call you, or they don't have a phone, or their phone doesn't work, or they called your office but they got the wrong number, and they end up in the ER, and the ER doesn't know what to do with them, so they admit them. Does that sound familiar? Yes. So what we're trying to do is we're trying to link everyone together who integrates and cares for the patient. So it's the primary care doctor, it's the social worker, it's the community agency out there that helps support that person with maybe transportation, or with housing, or with food security. All of those people are part of the puzzle. Unless we're all pulling together, we're not going to make a dent in this, because I've been doing this for 20 some odd years, and the same problems I saw when I first got out of residency, they exist today with the Medicaid population and with other populations too. I think the key point from this one is that what CMS is looking for, the way CMS will judge New York is successful, is if we can reduce ER visits by 25% in Medicaid population. These are avoidable ER visits, so again, the car accident, that kind of thing, we're excluding those. And avoidable hospital admissions in this same population. So that's those readmissions for the same thing. This is our PPS. We used to be called the Southern Tier Rural Integrated PPS. That was a long time ago. This is an old slide. But you can see that we go from Steuben to Delaware County. We are bigger in square miles than the state of Connecticut, but we have a much smaller population. So we're quite a rural area, but we do have a couple of centers of population within it. And even though you would think that, well, most people must live in Broome, Tioga County, actually for a Medicaid population, it's kind of spread out. So their biggest chunk is in the Broome, Tioga County area, but 30% of the Medicaid population for our area lives in the Schuyler, Tompkins, Cortland County. So we are a little bit diffuse. So who's in our partnership? Well, you can see all the hospitals are involved, some health homes are involved, there's 20 some odd skilled nursing facilities that are involved, some D&T centers, and we have an FQHC that's involved with us. A lot of primary care doctors are involved with us and other specialists. a lot of community-based organizations that have to do with some things that sound medical and some things that don't. Housing, food security, transportation. This is how we're set up. So we have a governing board, and the board has the hospital systems and the FQHC each have one seat on the board, and then the other seats on the board all come from those community-based organizations. Underneath that, we have we have 5 committees. 4 committees. Why am I missing one? What am I missing? Nominating committee, that's right. So we have a finance governance committee, and they are all the finance people, and they figure out, we all have this money from the state, how we're going to sort that out. We have a governance committee, clinical governance committee. I'm the chair of that committee. Some members of my committee are here in this room, and we're the people who look at all the policies that we want to standardize the way we treat our Medicaid patients with, and come up with something that's going to work for everybody, and then try to push that out to all of the organizations. We have an IT and data governance committee. If you think the IT needs and the problems you have in your practice are big, just imagine all of these partners, everyone is on a different system. None of the systems talk to each other or want to talk to each other. We have a lot of data that we need to sort out. And then we have a compliance and audit committee because the state says we have to have that. We decided that an area the size of Connecticut that had 9 counties was just too big of an area to manage. You know, this is not a PPS in New York City where they're defined by blocks. We're defined by counties. And so we thought the best way to bring this to a way that's going to work is to bring it down to a very functional level. So who are the local doctors and the local hospital and the local agencies that work together? Let's band those groups together and put them in a region. And we call those regional performing units. And so we have 4 of them. We have one in the south, which is Tioga and Broome County. We have the north one, which is Tompkins, Schuyler, and Cortland County. We have the east, which is Chenango and Delaware County. And then we have the west, which is Steuben and Chemung County. And so each of those RPUs has a structure. And within the structure, they each have quality committees that look at how we're going to accomplish these tasks that we have to accomplish. And in some of those RPUs, they felt that they had a particular need, so they needed to have more committees. And some of the RPUs said, you know, we just don't have the infrastructure to do the things that we want to do, so we're going to kind of combine some committees. So as an example, kind of hard to see in here, but in the North RPU, unlike many of you, I live in 3 counties where the majority of the primary care providers are independent, primary care practice. Do you guys do you know anyone who's in primary care practice that's independent anymore? Well, in our region they are. Oh, thank you. So not only do we have that, but many of those people don't even know what PCMH stands for. Now, most of you that are part of a big system are kind of on a journey to reaching PCMH accreditation, or you have some accreditation and you're trying to get to the 2014 standards. Well, many of the people in my area, you know, that's not even been on their radar. So our RPU decided we need to have a committee just focusing on that, just helping primary care practices get that PCMH certification, because you all know what a heavy lift that is. So we divided our committees up into kind of certain areas. So we have an onboarding committee. So this is the one that has to deal with all the projects about getting Medicaid patients and uninsured patients involved in this. How do we get them in? Because we can build a great structure, but if the patients are not interested in it, if they're not engaged in it, nothing's going to happen. So we have an onboarding committee. We also have, under kind of the engagement portion, we have behavioral health committees and we have a chronic disease committee, because we know from our data and from looking at the data for the 9-county region that 30% of the readmissions in our area have a behavioral health component. They may come to the ER with a medical issue, but there's a strong behavioral health component in there. And that's probably what brought them to the ER. And then we also have, as I said, a PCMH committee in our area. And in talking to some of the other RPUs, some of them are finding that they may have that same kind of need as well. These are the 11 projects that we as a PPS chose. And I'll tell you how we kind of worked that process. So we did a survey, a diagnostic survey of what was going on in our area. And our area is the 9 counties. What were the needs? What were the problems that we saw? You know, were we having issues with access? Were we having issues with engagement? Did we have a lot of uninsured people? Did we have a lot of disengaged Medicaid patients? What were the problems that we found? And then we went through and thought which of the 41, I think, options that we had, 41 projects that we had, which ones would help us work on correcting some of those problems. And we went through this in kind of an iterative manner, so we went through this process several times and changed some of the projects. But this is the final list that we presented to the state and that they approved. And I'll just talk about them a little bit briefly. So the first one, integrated delivery system. So what we saw was a huge problem for us was that there was no region-wide or community-wide integration of different agencies and programs. You know, you might be in New York City and Montefiore has a nursing home and they have an acute care hospital and they have a 5,000 physician integrated primary care, specialty care practices, and they have skilled nursing, and they have home nursing, and they have social work, and they have a psychiatry program. Well, we don't live in that kind of community. So we live in a community with a lot of different people doing a lot of different things, and we needed to get everyone talking together. Care transitions. So we know that a big problem is readmissions for Medicaid patients after discharge from hospital. So we need a better way of integrating patients that are being discharged back into the healthcare setting. So in the past, someone got discharged, they got a piece of paper, call your doctor, here's your scripts, you know, goodbye, have fun, and nothing happened. They didn't get the scripts, they didn't follow up with the doctor. 20 days later, they're back in the hospital with the same problem. So that was a project that we felt that we needed to work on. Interact. So how many of you have patients in nursing homes? Just a couple. So did you ever get a phone call from the nursing home saying, Mrs. Smith has a fever? And then you ask, well, what else is going on? Well, I don't know. Well, what's her blood pressure? I'll check. And they come back, tell you the blood pressure. What's her pulse? I'll check. What do her lungs sound like? I'll check. And so what happens, in frustration perhaps, the patients get sent to the ER. The ER gets a patient, they don't have much of a history, they don't know what to do with them. They do a UA, and it's positive or something. So they get admitted for a urinary tract infection. Oh. So Interact is a way of trying to prevent that cycle from happening. So it gives nursing homes a standard set of things that they need to do before they call you. Here's the things that you need to do. Here's what you need to present to the doctor, so the doctor can make a decision that says, okay, well, Mrs. Smith, she's just has a little bit of a fever. We're going to watch her tonight. I want you to give her some Tylenol. If things get worse, give me a call. Otherwise, we'll have someone see her in the morning. So we're working with all of the nursing homes in our communities to try to get them to engage in this Interact program. Community-based health navigation. this is about engaging Medicaid patients in their health process, getting them engaged and figuring out, how they can be healthy and improve themselves. Patient Activation Project 11. So this is about finding those Medicaid patients that don't utilize their Medicaid card. So they got the card, they never go see anyone, maybe they use the ER as their primary care. This is about how do we engage them with primary care. And what about the uninsured people? How do we get them hooked up with local providers? Integration of primary care and behavioral health services. So what we want, ultimately, our goal, to get behavioral health services in every primary care office or linked to every primary care office. That's a big goal. That is a huge lift. Crisis stabilization. So you're in a community agency and you get a phone call from the family member saying, so-and-so is acting really strange, they're screaming, they're yelling, I don't know what's going on, maybe that they have a history of mental illness, so what do you tell them to do? Go to the ER? If you can't go to the ER, call the police. What do the police do? They pick them up, they bring them to the ER. So do they need to be in jail? Probably not. Do they need to have a crisis evaluation? Yes. Do they need to be in the ER for 8 hours because that's how long it takes to get a crisis evaluation and get all the collateral from families? They probably don't need to be there. Do they need admission? Well, we find that of all the people brought in by the police for crisis, only about 20 or 30% get admitted. The rest go back home. I mean, we're on a first name basis with them too. So why don't we have behavioral health services go to them? So that's what crisis stabilization team is. Let's take that service to them if we can. So we just signed a contract in the PPS to establish our first big crisis stabilization team here in this county, and we intend to expand that to the other counties. Chronic disease management, palliative care, and PCMH. These are all programs that we're trying to integrate into your PCMH program. Infrastructure, strengthen infrastructure for mental health and substance abuse. My God, you just have to read the paper and that is a total mess. So we're trying to come up with ways that we can improve services for substance abuse people in our counties. And then chronic disease management, COPD, this is the same thing. We're trying to integrate that into your PCMH.